Hello, everyone. Thank you so much for joining us today. My name is Nicole Murphy. I work with Minogue Medical, and we are so happy to have you here for our webinar about training residents and fellows on robotic-assisted surgery. We have two very exciting speakers for you today. We have Dr. Jason Lee, and we also have Dr. Alysha Nensi. So we're going to get started right away with Dr. Jason Lee, but first I'm going to show you how at the end of the presentations we're going to do a question and answer period. And so I just want to refer you to the chat feature. I know by this point we're all very familiar with Zoom, but we are going to be using the chat feature to ask questions. I encourage you throughout the presentation to include your questions on the chat feature, and we'll take note of them to make sure they're addressed at the end of the presentation. But without further ado, we're going to get started with our first speaker. Our first speaker is Dr. Jason Lee. After graduating from med school and urology residency training at the University of Toronto, Dr. Lee went on to complete a minimally invasive urologic surgery fellowship at the University of California. California, Irvine. He also completed a master's degree in health professions education through the University of Illinois at Chicago and returned to the Division of Urology at U of T in 2012. He currently works at UHN, focusing on robotic surgery for kidney cancer, urologic management of stones, and kidney transplantation, and has served as a residency program director since 2017. Thanks so much for joining us today, Dr. Lee. We're excited to see your talk.
Great. Thanks, Nicole, for the nice introduction. And thanks again to Minogue for putting on this webinar. I'm excited and thankful for the opportunity to present our sort of experience in developing our robotic surgery training curriculum. So I'm going to share. We did this before, so it should work. Share my screen. All right. Is it working? Yes. All right. So a little bit about, where robotic surgery started to always appreciate where we're going. The first surgical robot was introduced way back in 1985 at Long Beach Memorial, where actually I got to work a little bit during my fellowship. And the first surgical robot was it's a basic surgical arm that helped with brain biopsies. And over the course of the late 80s, early 90s, there were several different surgical robots that were introduced. One of them was actually out in UBC. But surgical robotics didn't really blossom or take off until sort of mid 2000s, late 2000s, and Intuitive Surgical first came out with their Vinci standard model back in early 2000, late 90s, I think, early 2000. And since then, there's obviously been several different iterations of the robot. The most recent sort of platform is the XI and X platforms, as well as they have now recently released the single port platform. And for those of you that may remember, there was a lot of media and press about the dangers of robotic surgery, about how many complications were being caused by the robot, and there's a lot of litigation. I think to this day, Intuitive has not lost a single lawsuit, but there were a lot of lawsuits launched. And the reality was, when robotic surgery started, obviously this was mainly in the US, surgeons wanted to say, we can offer you robotic surgery. It's the new sexy thing. And I think the main reason why there were so many problems was that the surgeons weren't trained properly. So it was a lack of training. It's not like the robot was, artificial intelligence. It's not like Skynet, like in Terminator. It doesn't go rogue and do things on its own. It's largely remote control surgery. And so if the surgeon is going to cut into a vein, then the robot will do so. And so it was largely related to that. And I think that's very important when you look at our Canadian sort of adoption of robotics. It was a little bit more measured and tempered, partly because of our single payer healthcare system. So it was part of a result of that. But back in 2013, when I came back to Canada, there were only about 19 robots in play in Canada. And I think one or two of those were research robots. So you know, when I was in California, in one small county, there were probably 50 robots. So it's a very different world back then. Now, things have improved a little bit, but we're still, you know, way far behind what the US has. This is a little graph from 2013 showing all the different robots installed. It basically was for every 2 Burger Kings, there was a robot at some hospital somewhere. And so they were literally everywhere. Oops, sorry, slides aren't advancing. So this also meant that the training programs had, the trainees in the US had ample opportunity to have robotic surgery exposure. And so a lot of the times they did not have a sort of comprehensive curriculum. The residents just were involved in so many different robotic procedures. They sort of learned in the traditional, you know, apprenticeship style model, where they just got to see a lot of cases and eventually do some as well. In Canada, again, like I mentioned, we are improving. There's a majority of our medical schools in Canada now have a robotic, a Da Vinci robot at one of their hospitals. And if you look at, oh, sorry, I don't know why it keeps doing that. If you look at the number of robots now in Canada, again, we're still far behind some of the other, you know, developed countries, but we are improving. We now have not only academic sites with robots, but we now have community hospitals that have purchased and are using robots and offering robotic surgery to their patients as well. I think the lion's share of the robots installed are sort of in central East Coast Canada, in Ontario and Quebec. So there's clearly room to grow for surgical robots in Canada. And so, you know, why is it important to invest in education? I think, you know, the days of see one, do one, teach one are gone. I think patients won't accept it. I know definitely the high maintenance patients, as some people will call it in Toronto, we just will not accept that. And I think we as educators and clinicians shouldn't accept it either. And we have the ability to sort of get over the early learning curve of various types of surgery, including robotics, in outside the sort of OR, in a simulated scenario. And so as a residency program director, we're also moving towards a competency-based training in Canada. And so I think it's going to be very important to focus on a sort of stepwise competency-based robotics training curriculum and platform moving forward, and also ultimately improves the learning environment. So, you know, when a resident shows up and wants to sit on the console and, you know, he doesn't even know where his left hand is or his right hand is and can't move the camera, you know, it's frustrating. It's not safe. You know, I'm not going to let them do as much as, you know, a resident who has put in time to practice on the simulator, and she knows exactly how to move the camera. She knows how to you know, grab all the tissue safely. I'm going to let her do more, and it's going to be safer. And so both the faculty member and the resident are going to get more out of that sort of interaction. And ultimately, I think it's going to improve patient outcomes. The other thing that's important, I think, you know, while we're not anywhere near where the US is in robotics, a large number of our trainees are going to want to go to the US for fellowships. And a lot of the fellowships in the US sort of expect their trainees to come in having a decent, you know, skill set in robotic surgery. So that's going to be very important. You know, jobs for various specialties are better in the US right now. And so a decent number of our trainees may be going to the US for jobs. And so we want to prepare them adequately for that. But we also want to retain and attract the best surgeons. We want people to come back to Canada after doing their robotic fellowship and be able to make use of their skills and not have to worry about sort of practicing something totally different when they come back. And we also know robotic surgery is no longer a revolution. It's sort of an evolution. There are various other platforms for robotic surgery that are either have recently come out or going to come out in the near future. And so I think it's only going to become more pervasive. The democratization of robotic assisted surgery is going to significantly improve in the next few years. So what does a training, you know, curriculum look like? And so near the end of my fellowship, we wanted to take an evidence-based approach to this. So we sort of combed through all the literature, and I must admit, for some of this stuff, there's not too much literature, but we tried our best to sort of distill the literature out there and design sort of or outline the sort of most important principles of a robotic surgery training curriculum. And this was easy to do in the US with the high number of cases that are done robotically. But when I came back to Canada, obviously the volume here is less, albeit significantly increasing over the last few years. But the infrastructure and the training was sort of very haphazard and not very fulsome. And basically what I noticed we were doing was, with the help of Minogue, and we were putting these occasional workshops on where the residents or fellows would come to the OR. We'd basically show them in a non-stressful situation, without a patient there, the various components of the robot, how to dock the robot, sit on the console, how to use the console. But it's very labor intensive to set this up in the operating room after hours. And so we would do this, a couple times a year maximum. And so, really it's very hard to learn much in sort of cramming everything into a 3-4 hour workshop. And so what we started to do is create something that was a little bit more frequent. And we incorporated some basic skills, tasks that they can actually work on. We would track how well they're doing, how long it took them to do some of these standardized tasks, some of the errors they were making, and providing some feedback. But again, that was still very, very labor intensive. You needed a faculty member to be there all the time. And so we wanted to allow the residents and fellows a little bit more access to sort of deliberate practice where they can train on their own. So a few years back, we rented, at the time we didn't have one of our own, so we rented a Vinci surgical simulator, or DVSS. Most people call it just the backpack. And so we rented this for a 6-week period and sort of developed a curriculum for our trainees to work through various exercises. And sort of at face value, the residents and fellows loved this. They thought it was very valuable, but we wanted to look at, what's the ROI if we were going to purchase a simulator. And so we looked at it from an objective perspective, and we found that the simulator did have construct validity evidence. So it could, can discern those who are novice robotic surgeons from expert surgeons. And not only that, it had concurrent validity evidence. So those who did well on the simulator seemed to perform well on the actual robot as well. So we started to think about this. This is a very valuable piece of tech that we could incorporate into our training curriculum. So over the last few years, we've started to build on this curriculum. We've incorporated some didactic lectures. Obviously, COVID has put a damper on our course last year, but we in previous years we would get together and have sort of basic introductory lectures. We started to develop this in a multidisciplinary fashion. So the urology group would then break off, and we'd have lectures on robotic procedures like prostatectomy, partial nephrectomy. The gynae group would break off and have lectures about gynecologic robotic procedures, thoracics, gen surg, etc. So we really built a momentum over the last few years. The incorporation of the simulator, we now have a dedicated simulator here at TGH that we have incorporated into our curriculum, and it's been very valuable. We again wanted to look at what's the evidence to support continuing to run these admittedly labor-intensive curricula. And so what we found was, as one would hope, the bare minimum, these trainees improve their robotic skills after the course. Obviously that's the bare minimum we would need to see. We also noticed that those that were engaged in more of a competency-based curriculum, as opposed to a simple just time-based training curriculum, they tended to do better and retain their skills better. And again, there was some decay over time, but when we looked at these trainees 5-6 months later, they still retained their improved skills in robotic surgery. So clearly, there's a benefit to this kind of curriculum. And so we are continuing to provide this for our trainees. And when you look at the basic principles of a good simulation-based training program, there are various things that are required. And without the simulator, I don't know if we would be able to meet some of these necessities. And so last year or so, the Intuitive launched their newest simulator, which is dubbed the SimNOW, and it's sort of it has really allowed us to build a comprehensive training curriculum. The simulator not only has, basic skills, so they can work their way through a whole host of different basic skills from, learning how to move and handle the camera, how to utilize the clutch functionality, basic, object transfer, suturing, needle driving, all this stuff. They no longer have to learn how to do this on a patient. They can practice this in the simulator. I've used this simulator extensively myself, and the fidelity of it, is pretty impressive. It is quite nice. There are other robotic simulators out there, but obviously this one has the benefit of you sitting on the actual surgical console, the robotic console, and practicing these exercises. The other thing that has been really impressive are these procedure specific modules. And so not only do you work on the basic robotic skills, but then you start to learn on the techniques and the principles of the procedures that you're going to be doing robotically. So there's various procedures on there. There's videos on there that can guide you through some of the steps of those procedures, but then you can also do those steps yourself in this simulated environment. So really starting to put those basic skills, those little models that you were working on, and using those skills to sort of practice these procedures before you get to the operating room. And right now, the SimNOW, they're working on other procedures as well, but they offer a whole host of different modules like the radical prostatectomy, hysterectomy, hemicolectomy, hernia repair, lobectomy, etc. The other amazing thing about the SimNOW is it's very personalizable. So as program director, what I can do and have done is created these modules for the residents and fellows to work through. And I can pick and choose which exercises I want them to complete, which procedure-specific modules I want them to complete. And as they're going through the curriculum, based on what areas that we identify as weaknesses, we can tailor and change the modules to fit the needs of the trainee. So it's really nice. I can go in and see how far they've have gone, how they're performing, what their scores are, and sort of provide them with that kind of feedback. And so to make this a little bit more user-friendly, what I've done over the last 6 months or so, this whole COVID pandemic really pushed me to do this, is create a website or a learning management system where the residents can now apply for their own profile. And so on the website, they have a dashboard that shows all the various aspects of the curriculum that they need to complete. And we're looking to sort of, we've had a bit of a soft launch this year, and we're hoping to make this sort of a full mandatory curriculum for our residents. I think we'd be the first program, at least in urology in Canada, that sort of mandates a robotics training curriculum as part of their training. And so they can go through their dashboard and see, what have I completed? What do I still need to do? And the idea is that they would work through some of the basic skills prior to getting to the OR. So as a PGY 1, 2, 3, they'd work through a lot of these simulator exercises so that when they get to the OR, they will have completed a lot of this basic skills training. They don't need, as a staff man, I don't have to worry about, that the residents are going to know how to move their camera, let alone how to suture the urethra. So they can come and say, listen, I would like time on the console because I have completed all of these basic skills. And so we've worked on this. They can book time on the simulator like you would go online and book a massage with your RMT. You can pick a time and sort of put your name down and sort of go into the sim lab and work on your various exercises. And again, I can look on their SimNOW account and see how far they've come, what modules they've completed, what exercises they're doing well in. And each exercise breaks down sort of all the different technical aspects as well. So, economy of motion, a number of times that you're dropping the needle. So it's a lot of granular data there. But really, to be a good, to have good results, you need to incorporate it and integrate it into a full curriculum. And so what we've worked on is the ability to now provide residents with assessments in the real world, in the OR as well. So through this website, what the residents can do is go in, and once they eventually start to, do bedside assisting, they can then trigger an assessment request to their faculty member and say, hey, listen, can you assess how I did as a bedside surgeon? So through the website, they can send off an email to their faculty member. The faculty member will get a little request. They open the account and they basically tick off and score their various components of their skills. And so this first starts as a bedside assist, and then as they sort of graduate onto the console and they're doing actual robotic surgery, and we can assess how well they're doing on various aspects of their basic skills. And so as they continue to progress, they can then trigger sort of procedure-specific assessments. And so looking at the literature, there's a few different publications looking at sort of all the key steps of all the different procedures from an education perspective, as well as an outcomes perspective. And so the residents and fellows can then trigger these assessments so that the faculty member can assess the resident on how well did you drop the bladder, how well did you perform the urethral anastomosis, how well did you perform the dissection of the kidney, whatever it may be. There's the various steps, and they can track what steps they have done, what steps they haven't done, and so when they progress through their training, they can work on the areas of need. Where do we want to go with this? We want to be able to upload more procedure-specific teaching videos so the residents have access to some of these reference videos. There's a whole host of them online. You can look on YouTube, various, Intuitive has a bunch on their website, but we want to be able to sort of provide a one-stop shop place for them to review things. We're also looking to try to allow the residents to upload some of their performance videos so that some of the faculty members can go in and actually look at their videos and say, hey, listen, you should have grabbed this way, so they can get a bit more feedback. You can have peer-to-peer learning, so some of the residents may be able to go and look at each other's videos and comment, maybe do a little trash talking, who knows. And I think this kind of platform also lends itself well to potentially credentialing opportunities where we may be able to mandate new faculty members who want to adopt robotic surgery to sort of complete a comprehensive curriculum such as this. So that's sort of where we've gotten to. It's still obviously a work in progress. I think there's a lot of areas we can improve on, but we're really excited to be able to offer something like this to our trainees here at U of T, and continue to work with them to improve on this using, taking their feedback. So I think maybe I'll stop there and turn it back over to Nicole. Thanks.
Great. Thank you so much, Dr. Lee. We really appreciate you sharing your experience working with residents and building a curriculum. As a reminder, if you have any questions for Dr. Lee, I encourage you to put them in the chat now, and we can absolutely address them after Dr. Nensi has completed her presentation. With that, I'm going to pass it over to Dr. Nensi. Dr. Alysha Nensi received her undergraduate medical degree at Western University and then completed her residency in obstetrics and gynecology at McMaster University. She pursued a 2-year fellowship in minimally invasive gynecologic surgery at St. Michael's Hospital, while concurrently completing her Master's of Science in Healthcare Quality at Queen's University. She joined the staff at St. Michael's Hospital in 2020. Her clinical interests include minimally invasive surgery, including robotic and vaginal surgery, complex heteroscopy, and valvular disorders. Her research interests include quality improvement and patient safety in gynecology, perioperative operation, and enhanced recovery after surgery. Thanks so much for joining us today, Dr. Nensi.
Thanks so much for that intro, Nicole, and thanks to Minogue for inviting me today. My disclosure is that I recently completed fellowship training in robotics and am now a new staff. So my portion of the talk will really be focusing on providing education at a fellowship level. So in terms of an outline for this talk, so I'll briefly go over the current state of robotic training, and I know Dr. Lee commented a little bit on this already as well. And then we'll review some of the benefits of structured robotic surgery training for fellows in particular, as well as some strategies for curriculum development and implementation. And then lastly, I'll talk about the Intuitive Surgical Residency and Fellowship Equivalency Certificate. So as we just heard from Dr. Lee, very few residents right now in Canada are exposed to robotics during their residency training, and currently it's considered a fellowship level skill in almost all surgical specialties. Really, urology, gynecology, general surgery, and thoracics have been including fellowship level robotics trainings for a few years now, and it's recently expanded to ENT and cardiac surgery as well. And so again, we have almost 6,000 Da Vinci systems installed globally, the vast majority of those being in the States, and only 48 units in Canada currently. So the difference in exposure to residents to robotic surgery is largely related to the fewer number of robots in Canada. And so we have not only fewer exposures for trainees, but fewer practicing robotic surgeons who can actually train residents and fellows. So all that is to say that residents in Canada who want to perform robotic surgery in their practice often have to work to seek out programs that offer this training at a fellowship level. And looking at gynae specifically, because that's my background, one of our current fellows, Dr. Samantha Ben-Lolo, is actually doing a study, a survey-based study, looking at the current use of robotics in Ontario. Right now, we have 10 academic and community hospitals in Ontario currently using the Vinci robot, and gynecology has access to the robot in 6 of the 10 sites, 4 of which are academic and 2 of which are in the community. Currently, there are 19 gynecologic robotic surgeons in Ontario, training 3 to 4 fellows per year. Half of those are gynae oncology fellows and half of those are MIS fellows. And currently, the robot is funded by private donors, foundation, or the hospital administration themselves, not the Ministry of Health. And this is another huge barrier to increasing access to robotic technology right now in Canada. So how can we improve access to fellowship level robotics training? Because we can't rapidly increase the number of robots, and even if we could, we can't rapidly increase the number of robotic surgeons who can teach trainees. So for this reason, it's really vitally important that the sites that are offering robotic training to fellows do so in a standardized way. And so because currently most residency programs do not have a lot of exposure to robotics, fellowship is the first time that surgeons are actually gaining any sort of comfort on the console. And as this hopefully changes in the coming years, where exposure may increase during residency, our fellowship curriculums may also eventually have to change. But because there are so few training programs here currently, it's important to create a structured curriculum to ensure that fellows are getting adequate and consistent training in between programs. And the way that the fellowship curriculum actually differs from the residency one is that the learning curve is very different than a junior trainee who has to learn a brand new task. Most fellows are already starting fellowship with a strong foundation in both laparoscopy and open surgery. And robotics is essentially just melding those two. The instruments, the setup is quite similar to laparoscopy, but the fine movements and the wristed instruments mimic open surgery. So that is all to say that fellows are able to safely start using the robot on live patients quite quickly after they learn the basics regarding the system setup, the components, and are able to practice with the simulator. And then lastly, a structured curriculum also allows for the integration of clinical, teaching, and research objectives that actually meet what each fellow needs. Because fellowships are usually much shorter than residency, usually somewhere between 1 to 3 years, it's really imperative that fellows build a strong foundation for their future career goals, and that the fellowship curriculum should sort of tailor their experience to that. So I think that the best way to explain really both the benefits of a robotics program and to give an example of a curriculum is to actually give an example. So I was fortunate enough to have my robotics training at St. Michael's Hospital in Toronto. Currently, it's the only site in Canada training gynae MIS fellows on the robot. All the other programs in gynecology are currently for gynae oncology. Hopefully, as the robot expands to other sites, this will change in the next few years. But currently, being the only site, our fellowship director, Dr. Deborah Robertson, and the other members of the group, Dr. Sari Kivez and Dr. Andrea Simpson, have worked hard over the last few years to build a comprehensive fellowship program. And so far, fellows graduating from this program have gone on to work at hospitals not only in Canada and the United States, but all around the world. So with respect to this fellowship, most OBGYN residents have little to no exposure to robotic surgery during residency, but we know there is a role for it. So there are evidence-based benefits in GYN oncology and in select patients with benign pathology. So those patients who are morbidly obese, those with large posterior fibroids, those with complex endometriosis. So this MIS fellowship really aims to teach advanced surgical techniques, including the management of these complex patients. At St. Mike's, this is a 2-year program with 1 fellow accepted each year, and the fellows participate concurrently in both clinical and research projects. Right now, we have 4 robotic surgeons, each operating once per month on the robot. So at least 1 day a week, our fellows are participating in robotic surgery. So our robotic curriculum essentially has 3 key elements. The first is the development of technical skills with the robot. The second is the management of the complex patients and pathology that we're dealing with. And the third is engagement in robotics research. So in general, first-year fellows spend the first few months of fellowship completing some didactic coursework through the Vinci community website, and then participating in situ training with the console and the cart in the actual operating room, and are of course still present in the OR during robotics cases, which are usually being performed by the attending and the senior fellow. And then by the fall, so the fellowship generally starts in July. By the fall, so after a month or two, they're usually ready to begin operating with the robot, again, starting as the assist and then gradually doing more and more of the case. So the principle here is really the element of graduated autonomy. So the fellows are participating in increasingly complex and higher risk portions of the procedure. So at the beginning, starting with things like suturing of the vaginal cuff, gradually moving on to securing some of the more vascular pedicles during hysterectomy. And then by January to February, so usually within 6 months of starting fellowship, most fellows are actually able to complete the entire case as the primary console surgeon, and then they spend the rest of their 1.5 years really finessing their skills. So this is not a skill that takes a long time to learn for our fellows. And this structure actually allows us to graduate high volume robotic surgeons. As we talk more and more about outcomes related to high volume surgeons, this is one way that we can really guarantee this. Personally, I completed 100 robotics cases during my fellowship, 20 as the bedside assist and 80 as the primary console surgeon. So then the other element is really the management of our complex patients and pathology. So our clinical fellows see these complex patients for their initial consultation in clinic. They're then responsible for developing a care plan for these patients for their surgery as well as their preoperative optimization. And this really helps transition to practice because they're really getting used to seeing these patients all the way from the office to the operating room. Then they also have perioperative considerations for our complex patients. For example, we operate on a lot of morbidly obese patients, BMI 40, 50, 60, 70. So really getting a sense of, adequate positioning for these patients, intraoperative troubleshooting with our robotic instruments and the robotic console, and then also considerations for postoperative care for these patients as well. And then the last element is really engagement in robotics research. And this is the place really where having a robotic fellowship program is a huge value add, not only for the department, but also for the hospital. So robotic technology still requires a lot of work to be done in terms of cost efficiency and looking at outcomes. And I think really the only way for us to advocate for its more widespread adoption is to do research and to publish data. And in our program, we've really been able to tailor our fellows' research towards their career objectives, but also having them participate in current studies being run by our department. So again, personally, I have an interest in patient safety and quality improvement. And so one of the big projects that I was able to do as a fellow was to look at how we can use some of those lean methodology exercises to optimize our operating room efficiency. So to give you an example, we know that the robotic OR is a complex environment, and it really requires good coordination between the surgical team, the anesthesia team, the nursing staff. And we were finding that a lot of our cases were getting delayed just because there were so many moving parts. And so one thing that we did is we actually made a process map. Here, you don't have to read all the elements, but we actually made a process map of every single step of a robotic hysterectomy that all members of the team were participating in. And then what we did is we invited all of these 3 groups together, our nursing team, our anesthesia team, and our robotic surgeons, to review this process map together, to give some input. Where did they think that there was inefficiencies? Where did they think there was room for improvement? And each team member could put sticky notes up on, we had projected this process map onto the wall. And you can see that there were clusters of certain steps where all members of the group felt that there was room for improvement. So again, as a multidisciplinary group, we came up with some strategies for how can we make these steps more efficient. And so what our result was is we created a future state process map. And again, you can see here where these green bursts are. These were some suggestions of things that we could change during our robotic hysterectomy cases in an attempt to improve efficiency. And so what we noticed is we captured all of the mean case times for our hysterectomies in the 12 months before introducing this future state process map. And right after its introduction, over those next 6 months, we were able to see that mean case time decreased by 28 minutes, which initially didn't seem like that much time, but because we usually try and do 2 robotics cases a day, we were actually able to decrease our second case cancellation rate by 70%. And most of the cases that we're doing in our robotics ORs are actually for women with early stage endometrial cancers. And so this was a huge value add for our patients, for our hospital, and for our department as well. So this was a huge benefit of one of the research projects that I was able to do. And currently, just going back, some of the projects that we're working on are in terms of continuous quality improvement. So continuing to optimize our OR efficiency, reviewing our surgical outcomes in our morbidly obese patients, and also looking at VTE prophylaxis in our complex surgical patients as well. All right, so lastly, the last thing that I wanted to touch on is how can residents and fellows get certified in robotic surgery in a way that is meaningful and reproducible? So, residency training has transitioned to competency by design with specific milestones and competencies leading eventually to a transition to practice. Contrasting that, fellowship training in Canada is much more variable, and most fellowship programs are actually regulated by the university or national or international credentialing societies rather than the Royal College itself. So Intuitive Surgical actually has an equivalency certificate that is useful for documenting progress. So it allows surgical fellows who have trained with the robot to actually show that they have completed specific didactic bedside training, as well as a minimum number of cases as an assistant and as the console surgeon. So this can be used actually by both the fellows and the attendings at the time of cases to actually review the case and give feedback on an ad hoc basis. It can also be used by the program director periodically to make sure that the fellow is on track. But importantly, it's also something that the fellow or even residents can take with them when they graduate. So no matter where in the world they may be going to work, when it comes time for credentialing, they can say, look, I have this certificate that shows that I completed didactic coursework, I completed a minimum number of cases, and here's actually the feedback from my program director. And the nice thing is this equivalency certificate can be used internationally, no matter where a resident or a fellow may go on to practice. And the components of the equivalency certificate first include the online course and assessments. So those are some of the basics, and the course topics include sort of the terminology for the system, what the functions are of the console, and some of the safety features. Then they can move on to the in-service training. So these course topics include things like reviewing docking of the surgical robot, port placement, how to use some of the wristed instruments, and then the emergency procedures as well. And then finally, as I mentioned, the fellows can go on to actually perform their minimum caseload. So at following all of this, their program director can go on to actually submit a letter of support, and then they actually receive a certificate from Intuitive Surgical, which then they can take with them no matter where they go. So in summary, I think definitely opportunities exist for expanding fellowship level robotics training in Canada. We're definitely not at the level of the States, and I think there's definitely the need as more residents are trained. I think there's going to be more and more demand for robotic surgeons, and structured robotics curriculums can be used to standardize our training programs to ensure that our fellows are equipped to achieve both their clinical and their research objectives. And then lastly, the Intuitive Surgical certificate can be incorporated into the training programs to both guide curriculum development and also to aid with credentialing. And I just wanted to give a shout out to the rest of my colleagues here. I was lucky enough to have trained with them as a fellow, and I'm now lucky enough to call them my colleagues. I have my contact information there. I'm happy to answer any questions offline. I know we have a question and answer period at the end as well. So thank you again to Nicole, and thanks to Dr. Lee as well for addressing some of these already. And I'm happy to answer some questions moving forward.
Awesome. Thank you so much, Dr. Nensi, for your presentation. We really appreciate hearing about your experience from the fellowship side and moving into a staff position as well. So we're going to get started into the question and answer period, and there's been lots of questions coming into the chat. I encourage you to continue entering them in, but we're going to get started with our first question. The first question is for both of you, so we'll start with Dr. Lee. Do you define specific surgical outcomes for your residents or fellows by the end of their program? So Dr. Lee, if you want to speak to that first.
Sure. So as part of our curriculum, we have mandated a certain number of cases that they need to complete. And also we want them to complete all the basic simulation modules. As part of our sort of outline curriculum, there's all these steps that they need to complete in a stepwise fashion. So in order to get onto the console, they need to complete all the steps ahead of the prior to that step. So we have required them to do all this stuff in a stepwise fashion. As far as intraoperatively, you know, as Alysha mentioned, we wanted to align our curriculum with what Intuitive is offering with respect to the certification of completion. And so at the end of our curriculum, if you meet all the objectives, you will be eligible for the Intuitive certificate as well. Now, not all residents will be able to get those numbers depending on their interest, depending on their rotations and things like that. And obviously various universities have more or less case volume for certain types of procedures. So some sites may be able to meet those numbers and some won't. You know, in the US, if you look at all the urology programs, they have no problem meeting those numbers. So what we've done is actually sort of broken down our curriculum into a basic curriculum and an advanced, where once you finish the advanced curriculum, you will be eligible for the Intuitive certificate. If you complete just the basic, you know, you'll get a University of Toronto UHN certificate of completion. Again, it does not certify you in any way with Intuitive, but it's a stepping stone that you can use to sort of get to the next step wherever you're going, fellowship or whatnot. So that's what we've done to date.
Excellent. Dr. Nensi, do you have anything to add about the specific surgical objectives at the end of fellowship?
Yeah, so I mean, we have a few, you know, major big types of surgery that we train our fellows for in terms of gynecology specifically, the big ones being robotic hysterectomy and robotic myomectomy. So similar to other complex surgical procedures that our fellows are gaining experience with during their fellowship training, we really try and focus on initially thinking about how we're going to, you know, get these patients to the OR in the first place. So part of the objectives are on the appropriate preoperative selection of patients and optimizing them for surgery. And then usually before each case, you know, especially early on, usually whoever the staff is with the fellow in the room will sort of sit down with them and review, you know, what are the steps you have been doing so far on the robot? What will be the specific objectives for this case? And then gradually over a period of, you know, 4 to 6 months at the beginning of their fellowship, they're able to quite quickly work their way up to being able to, you know, independently perform the task. You know, it's a little bit different than residents in that it's a much tighter timeline, but luckily, usually a lot of our fellows already have such strong laparoscopic skills. They've done a lot of simulation. They're very comfortable with the principles of surgery. So it's mainly just getting used to the components of the console. And that's why they really, over the first few months of the fellowship, spend a lot of time just focusing on the safety element, because, you know, they're really quite well versed in, you know, advanced laparoscopy, but really getting used to the robotic console, being able to troubleshoot with if there's an issue with an arm or an instrument, if it doesn't come out or if it doesn't go in, if your electrosurgery is not working. So it's mainly the stepwise progression is really getting used to the console for the first couple of months, graduated autonomy for each of our big surgical procedures that we're doing, and then finally really finessing the complexity of cases they're doing for the last year and a half. And that timeline has worked well. You know, we've been training fellows at St. Mike's for 5 to almost 10 years. So that's been our approach.
Great, thank you. Our next question is about the requirements before someone gets onto the console. I know, Dr. Lee, you have a checklist of what they need to do prior to getting access to the console. And we were wondering, is watching narrated procedure videos part of the standard training requirements before getting console time?
Yes, for our residents, when you look on the Intuitive website, they have basic videos on the technical aspects of the robotics platform, but also surgical procedures as well. And so they need to watch. So we basically keep track of which videos they've watched, and they just get a tick box once they've watched all the required videos. So I think that question gets to the point of, it's not just the basic skills, they need to understand the steps of the procedure as well. And some procedures lend themselves better to robotics than others. I mean, like a robotic partial nephrectomy, it's the same as laparoscopic partial nephrectomy, it's just with the robotic platform. So from that perspective, there's nothing specific with the robot, it's just applying the robotic platform to that procedure. And so we do require that they have sort of that part of the cognitive learning piece met before they sit on the console.
Excellent, thank you. Dr. Nensi, for the fellowship program, are they required to do procedure video watching as well, or is it simply learned in the OR by like shadowing?
Yeah, so the nice thing is, again, because unlike residents that are sort of traveling to different sites, may have shorter rotations at the same place, our fellows are with us for the full 2 years. So generally at the beginning, while the fellows are still participating in some of the didactic coursework, they are still around and they are still surgical fellows. So in the ORs, you know, when they're there observing in real time the staff and the senior fellows operating, that's when they're really given the in situ sort of ad hoc teaching about, here are the steps, here's what I do for safety, because definitely the best way to gain experience is not only doing the surgery yourself, but especially at the beginning, sort of seeing how even the attending and the senior are working together. And then that allows them to sort of transition into being an actual surgeon, either as the assist or as the primary console surgeon a few months after starting. So, you know, definitely we have lots of video footage of our cases, but definitely getting the fellows in the OR early for our robotic stays is a really important part of our fellowship program.
Excellent, thank you. This is a question specifically, Dr. Lee, for you about the residents. Do you currently use surgical assistants for the bedside, or is it the residents that are acting as a bedside assist? And with varied interest in robotics from residents, how do you manage bedside assistance versus console time to optimize exposure?
So most of our cases have a resident and a fellow involved. So, I mean, that's a bit of a luxury, in particular, if you've only got one console, it makes it a bit more challenging for teaching. But so what we do often is, you know, really have sort of a preoperative education timeout. We sit down and say, what parts of the procedure is the resident going to do? What parts of the procedure is the fellow going to do, based on the cases that they've done up till now, and based on the feedback of what parts of the procedure have they not gotten to do yet. And obviously there's a bit of a stepwise, you know, natural sort of progression of certain parts of the case are more advanced. And so we won't let the resident do that initially until they've demonstrated to us some competency. And that will be based on those assessments. You know, for the rooms or sites. So at UHN, we have one room with only one console, another room with two consoles. So depending on the day, which room you're assigned to, it definitely is beneficial to have two consoles from an education perspective, but then you need two extra people in the OR. So you need yourself plus a resident and or a surgical tech or a fellow. I think in some universities, they definitely utilize a scrub tech or a nurse tech that will do all the bedside assisting. I think there is value in learning how to do bedside assisting for the residents. It teaches them sort of basic laparoscopic skills, but also it allows them to learn the procedure itself. You know, when you really know how to assist a case, it sort of helps you understand the procedure itself. So hopefully that answers the question.
Excellent, thank you. The next question is regarding fellowship. So what is the value of having the Intuitive Fellowship Equivalency Certificate leaving your fellowship? What does that kind of allow you to do?
Yeah, so I mean, that's super valuable for a couple of reasons. Firstly, you know, it's something that is transferable no matter where you go. And because, especially in Canada, you know, robotics is not that widespread. And so, you know, if you're trying to get credentialed at a new hospital, it is a way to say, you know, this is the number of cases that I've done. Here's how many I've assisted. Here's how many I've done as a primary. It also includes a letter of support from either your program director or your chief of surgery. And it also includes all of the safety coursework and background that you've done. So it allows somebody who has done a robotics fellowship, or, you know, hopefully at some point training even in residency, taking it with them whenever they're going to negotiate their job, wherever they're starting, whether here in Canada or anywhere around the world, as something that is transferable, right? So we have, you know, your MD degree, we have your Royal College certification that you're a fellow of the Royal College. And this is just another way of having some more formalized credentialing, saying I completed XYZ, and so I am safe to start practicing here at your hospital.
Excellent, thank you. Our next question is, do you feel that the simulator replaces the need for a teaching console? For those of you who don't know, the Da Vinci robot can be purchased with 1 or 2 consoles, and you also have the option of adding a simulator. So I don't know which one of you may be best to speak to the value of a simulator versus a training console, or having both. Maybe Dr. Lee, do you want to start?
Sure. You know, I think the simulator really helps with getting trainees over that initial safety learning curve. You know, if you've never done any robotics, to try to learn robotics fully on the patient, it's painful to watch. It's painful to do, and so it really allows you know, trainees to get over that initial, you know, basic safety learning curve in a low stakes environment. They can make lots of mistakes. I think the simulator is very valuable. The teaching console is a bit different. I think, you know, in the room with only one console, sometimes I have to scrub in and scrub out. It logistically can be a little bit more time consuming when you want to teach someone how to do various steps of the procedure. That's why having a fellow and a resident is actually nice, because, you know, I may say with the fellow, you and I will do this case, and then the second robotic case, me and the resident will do it while the other person is assisting. And so that is very helpful to have that second console for sites where, you know, you have a lot of trainees, and or you're a community site that wants to train up a bunch of faculty quickly. I think that having that second console is very valuable from an education perspective.
Yeah, I would echo that as well. I almost feel like they have 2 separate roles, where the simulator is really great for that introduction to you know, specific skills, how to use the foot pedals, what instruments you have access to, what their limitations are. But the second console, I think, would be best for really, you know, at the time, direction and guidance while you've graduated from the steps of being able to do the simulator. And I mean, you can still use them concurrently, because it does have the option to then actually do case specific simulations. But I think the console is really more useful for an in the moment teaching and re-guidance, but it also does require an extra person. So the simulator is nice for sort of something you can do on your own time outside of the OR.
Excellent, thank you both. The next question we have is, I believe it was answered a little bit already by you, Dr. Lee, but I'll just make sure there's nothing else we want to add. But how do you decide at the end of residency, is there a robotics certification with potential levels of competency? For residents, is there like a specific metric or assessment? And is this validated, and therefore you can certify it as PD?
Yeah, so that's a very hotly contentious topic. You know, the various societies, OBGYN, urology, general surgery, no one wants to touch sort of this, what truly makes it you certified. So a lot of it has been left to industry, and there's certain, you know, coursework that you need to do. But basically what we have now for Intuitive is this certificate of training completion. And so you know, as a purist, from an education perspective, as a purist, the problem with that is it's just pure volume based. You need to do 10 of these cases, 20 of these cases, etc. And so we all know, you know, it may take me 50 cases to learn how to do a hysterectomy, and Alysha will do it in 5. Like, why does she have to do 20? She can get it, she'd be competent in 5. So the numbers is not ideal, but that's what we have, and that's what Intuitive is requiring. And so what we've done in our curriculum is set it up so that if you complete the entirety of the basic and advanced modules, you will be eligible to apply with your program director's support, like Alysha mentioned, for the fellowship, to apply for that certificate. But there may be some residents who either are not interested in robotics or don't have or there may be sites, training sites that don't have the numbers. So what we want to provide is that that sort of basic certificate of completion that says, listen, I've done all my basic training, I'm over my safety curve. And what we've added in our curriculum is a component of sort of objective assessment, not just case volume. So, you know, I think no society, no hospital, nobody wants to stick their neck out and say, this is what you need to do to be competent, because there's a lot of liability when you do that. But short of that, I think, you know, we're doing the best we can. And there's not a lot of literature to say X number of cases equals competency and safety, right? That's the hard part as well.
Excellent, thank you. That brings us to the end of my list of questions that I've seen. So I'm just going to share my screen one last time before we head out for today. So what I'm showing you right now is a couple of QR codes to Minogue Medical's social media pages. I encourage you to give these a follow. We've been making a lot of effort to share webinars like these that are relevant and active discussions about robotics in Canada. So I encourage you to give some of these pages a follow to stay up to date on what exciting events we have coming up next. Also, I wanted to say thank you so much to both of our speakers for today, both Dr. Lee and Dr. Nensi. Having your experience shared was very valuable. And I know resident and fellow curriculum and training is something that has been a very hot topic across the robotic groups in Canada as well as in the States. So thank you very much for sharing your experience. I know this is a very valuable thing as we're working on developing robotic assisted surgery